The topic for today's discussion is about the acute conditions of the liver. We have been discussing about the different infective conditions which are related to the liver, especially the chronic conditions have been discussed in the past few lectures. But today we'll be more precisely talking about the acute conditions of the liver, which can be acute infective processes, or like the abscess, which is a kind of the complicated collection of the localized part of the inflammation or the infection. So we'll be talking in today's lecture about this. If we talk about the somehow the drainage of the liver, we all know that actually the venous blood comes to the portal blood before it goes to the systemic circulation and goes to the right atrium of the heart, to the vena cavas. So it's a kind of the connection which is actually connecting the portal blood to the systemic circulation in the liver. So whatever the process of the drainage is, especially the drainage from the lower limbs and the drainage from the intestine, they're coming and draining into the portal blood, and then obviously they go through the hepatic circulation, and by through the process in the portal vein, then enters into the vena cava, especially the inferior vena cava. So all the blood first comes to the liver for the detoxification, and then it by the help of the caval system, especially the inferior vena cava, the blood goes to the right atrium of the heart, and then obviously the blood goes to the lungs for the saturation. But you have to keep in mind how the infections are being transmitted to the liver is the root of the photosystemic, anastomosis, or by the process of the systemic blood first coming to the portal blood and then going to the right atrium of the heart. So that's the main pathway for the infective etiologies which are coming involving the circulation, or which are even the part of the intestines or the part of the lower GI. So we'll be talking about these infections one by one. First of all, the thing which we need to be discussed is about the ascending cholangitis. So we all know that if any kind of the infection is present in the liver, or is present into the lower intestine, or present in the duodenum, there can be some kind of connection with the hepatic and the biliary channels. So the hepatic sinusoids, they enter and they actually make the right and the left hepatic duct, and the right and the left hepatic duct then combine together and they form the common hepatic duct. The common hepatic duct, along with the cystic duct, they make the common bile duct, and the common bile duct along with the main pancreatic duct, it opens into the second part of the duodenum. So this channel is somehow very, very much important, because if there is any stone which is present in the gallbladder, it comes to the cystic duct, it can come to the common bile duct, and it can come to the duodenum, or it can cause, the stone may pass all different from the gallbladder and it comes to the biliary channels. So a special, a triad would be present in those patients who present to you with ascending cholangitis. And if you talk about the specific etiology behind the ascending cholangitis, do not forget about the gallstones. So they are the most important cause for the ascending cholangitis. And obviously, if there is a stone which is actually slipping all the way from the gallbladder, comes to the common bile duct, then obviously there would be dilatation of the CBD, and there would be stasis of the bile. And whenever there is stasis of any kind of a secretion, it's prone to the infective process, and the bacteria may actually accumulate in that process, and they cause ascending cholangitis. They cause the inflammation of the biliary channels. And the patient may present to you with a right upper quadrant pain, with the fever and the chills. Fever will be the indicative sign for the acute infection. So, and the third thing which completes a triad is the right upper quadrant pain, fever, and especially the vomiting, it can be present. So always remember, if you could appreciate here in this diagram, that this is actually the biliary channel, okay? So these are the main common hepatic, this is the common hepatic duct, and is actually forming by the fusion of the right hepatic duct and the left hepatic duct. So the right and the left hepatic ducts, they combine together and they form the common hepatic duct. This is the gallbladder, and you can see the stones in the gallbladder. So actually what happens is that this is the cystic duct. So the cystic duct combines with this, which is the common hepatic duct, and they combine together and they form the common bile duct. And then common bile duct, along with the main pancreatic duct, they open into the second part of the duodenum, which is this. So what happens if some stone is present in the gallbladder and it slips all the way to the cystic duct and it comes to the common bile duct? The stone is the major pathology behind the process of the cholangitis. So it would be obstructing the passage of the bile. There would be stasis of the bile, and the patient will classically present to you with the triad of the symptoms, which is called as a Charcot triad. So if you talk about the Charcot triad, there are three important cardinal signs: obstructive jaundice, right upper quadrant pain, and rigors in the chills because of the fever. So how classically the patient is going to present to you, obviously these fever, right upper quadrant pain, and obstructive jaundice. And sometimes the patient, if he is already known of the cholelithiasis, so if you ask that patient, or you try to probe, or you try to get the history out of that patient, he will tell you that I have actually the gallstones, and somehow you will, if there is clinical picture of the obstructive jaundice and the patient is complaining of the yellowish sclera, or the patient is complaining about the dark color urine or the dark colored stools, that means there is possibility of the obstructive jaundice along with the right upper quadrant pain. Now you have to differentiate the hemolytic jaundice from that of the obstructive jaundice. All kind of the jaundice, the patient will actually present to you with a yellowish discoloration of the skin, sclera, or sometimes darker colored urine and darker color of the stools, actually pale color of the stools. So the patient would, if he has the history of the hemolytic jaundice, or the patient is actually presenting to you with a jaundice, he won't be having the right upper quadrant pain. So if the classical triad is present, like the Charcot triad, he's having fever and chills, he is giving you the history of cholelithiasis, and he has obstructive jaundice, and he is also complaining of the right upper quadrant pain, then you have to think about the ascending cholangitis. So always remember the clinical jaundice, rigors, and chills, which are associated with the fever, and the tender right upper quadrant. So this actually classically makes the Charcot triad, and it can help you if you pick up these clinical features. It can help you distinguishing between the obstructive jaundice and the hemolytic jaundice, because all kind of the jaundice presents with the same clinical picture, a yellowish discoloration. So how you can differentiate the cause of the jaundice, whether it's the obstructive jaundice or the hemolytic jaundice, you have to take the proper history. He would be giving you a proper history of cholelithiasis if he's already known and he has done his ultrasound in the past. But specific would be the right upper quadrant pain, and when you try to examine that patient, there would be tenderness present in the right upper quadrant. How you're actually trying to make the diagnosis, you always start from the history in the clinical examination. So he would be giving you the history of jaundice, he would be giving you the history of fever, and he would be giving you the history of especially right upper quadrant pain. And then you try to examine that patient, and you find out that clinically he is jaundice. There's yellowish discoloration of the skin, yellowish discoloration of the sclera, and there is tender right hypochondrium in the right upper quadrant. And when you investigate such a case, obviously the first line would be the blood CP, the LFTs, RFTs, serum electrolytes as well. But the most significant investigation related to the ascending cholangitis would be blood CP and LFT. So if he is having ascending cholangitis, obviously the total leukocyte count would be raised. Since it is the acute infection, so the neutrophil count would be more as compared to the lymphocytic count. So the increased TLC, and number two thing is a liver function test. So there would be derangement of the liver function test. You order for the total bilirubin levels, you order for the ALT, you order for the ALP, alkaline phosphatase. And alanine aminotransferase. So ALT is actually coming from the liver, and ALP specifically is coming from the gallbladder and the biliary channels. So there would be stasis of the bilirubin, so that's where the total bilirubin level would be increased. ALT would be increased, but not that much as compared to the ALP. ALP would be more increased, so that would give you the indication that this is ascending cholangitis, and it's causing typically obstructive picture of the patient. And then another important test which is going to help you is the direct and the indirect bilirubin. So the direct bilirubin would be raised in the hemolytic jaundice, and indirect bilirubin would be raised in the obstructive jaundice. So the obstructive jaundice, that means there is some kind of problem with the gallbladder, or the history of the stones in the gallbladder, and it may slip down all the way through the cystic duct to the common bile duct and is causing the ascending cholangitis. So for the diagnosis, baseline investigation, there would be total leukocyte count, increased total leukocyte count with the differential count of increase with the neutrophils. And then obviously you have to order for the liver function test. Total bilirubin level would be increased. And if you further categorize direct and indirect, so indirect bilirubin would be more raised as compared to the direct bilirubin. ALT would be raised, and ALP would be more raised as compared to the ALT. But significant okay, you are done. You know that it's obstructive jaundice, but there can be some other causes for the obstructive jaundice. If there are periampullary carcinomas, or if there is a CA head of the pancreas, it may cause obstructive jaundice. Then how you are going to differentiate? Obviously, ultrasonography is going to help you. CT is going to help you. So you order for the non-invasive and then the invasive investigation. So ultrasound will tell you that there is dilatation in the CBD. The total diameter of the CBD is increased. Ultrasound will tell you that there are multiple calculi in the gallbladder. And one of then if there's a dilatation of the CBD, which is the common bile duct, that means the stone is actually obstructing the way, and it's dilating the lumen of the common bile duct. So its thickness is increased, its diameter is increased. If only thickness is increased, and with the diameters and the fever, and you actually relate everything, the clinical findings with the diagnostic findings, you relate to everything. So talking about the diagnosis, ultrasonography, liver function test, and the blood culture. Why blood culture is important? Because there would be some kind of the pathogen responsible for that, which can be streptococcus, or which can be staphylococcus, which can be E. coli. The normal flora, the gram negative and anaerobes would be obviously found out to be there. So it's better before you start the antibiotics, you send actually the blood culture, so that you can start the antibiotics specific to that blood culture sensitivity. So clinically, obstructive jaundice, rigors and chills, and right upper quadrant pain. These are the three important cardinal symptoms which are making actually the Charcot Triad, and it's giving you the impression of the ascending cholangitis. Then clinical examination, tender right hypochondrium with the fever, and then specific investigation. So you start from the baseline investigation, blood CP, there would be increase in the total leukocyte count with increase in the neutrophil count, and you order for the liver function test. Bilirubin would be increased, LT would be increased, not that significantly, but that would be increased as well. And alkaline phosphatase, which is actually coming from the gallbladder, so that would be increased more. And then you order for the direct and indirect bilirubin levels. And indirect bilirubin would be more raised as compared to the direct, and the gamma GT would be increased in case of the ascending cholangitis as well. Then you have to find out the cause, and you move to the ultrasonography. So multiple calculi which are present in the gallbladder, that would be the indicative sign. And then multiple dilatations which are present in the common bile duct channel, that would be indicative, of course. And the diameter and the thickness of the CVD is again important. Now, you also need to differentiate ascending cholangitis from acute cholecystitis. So if it is acute cholecystitis, then how would you actually differentiate between ascending cholangitis and the patient would have fever, patient would have right upper quadrant pain, but there would not be the findings of obstructive jaundice, right? So that's how you can differentiate between ascending cholangitis and acute cholecystitis. If acute cholecystitis is present, that means that the infection is at the level of the gallbladder. So there would be no obstruction, right? So obstruction comes when it comes to the channel of the common bile duct, or the drainage is being affected. So in case of the acute cholecystitis, fever would be present, total leukocytic count would be present, right upper quadrant pain would be present, but there would be no jaundice, which is the cardinal sign for the ascending cholangitis. And remember, ultrasonography, liver function test, and then blood cultures if you want to start patient on appropriate antibiotics. So talking about the management strategies about ascending cholangitis, so obviously you need to treat the infection, and you need to put the patient on good hydration status, and you need to give good antibiotic cover to such patients. So the first line, broad spectrum antibiotic. Why broad spectrum antibiotic? Because you do not actually know what is the culture sensitivity when the patient is actually coming to you. So you need to start the broad spectrum, so it covers mostly the flora of the gut, like the gram negative. You have to give the gram negative cover, you have to give the gram positive cover, and you need to give the anaerobic cover. So if you give a broad spectrum antibiotic like the 4th generation cephalosporin, or you put the patient on a maronam or aminoglycosides, and then you also combining it with a flagell, which is metronidazole, and it's giving you the anaerobic cover. So you can actually use all of this combination of broad spectrum antibiotic with the anaerobic cover. That is, you are using maybe the 4th generation cephalosporins, or you're using the aminoglycosides, or you're using maronam or the tynam, and combining with the flagell. Rehydration is somehow very, very much important, because again, you do not know, or you're not sure about the third space law. So that's why it's important to rehydrate the patient. Then again, like all other infections, because there's a biliary stasis, and the proper drainage of the bilirubin is being affected, and it's actually the stasis of the bilirubin is worsening the condition. So what you need to do is you need to put the drain, and you need to drain the bile. So how can you drain the bile? It can be either endoscopic biliary drainage, which is called ERCP, and stenting, endoscopic retrograde cholangiopancreatography, and you combine it with the stenting. So actually you put the endoscope, and you go all the way visualizing in the camera. You focus on the common bile duct channel, and then you put the stent up using the endoscopic visualization. The other thing, if it's difficult for ERCP, and because of the infection, its stenting is not successful, the other mean you can use is a percutaneous transhepatic drainage. So in the percutaneous transhepatic drainage, you actually go all the way through the skin up just to the right upper quadrant, and along the costal margin, you pierce the skin, and you directly go to the liver, and you try to and do the percutaneous transhepatic all the way going through the liver, and then it's all under the endoscopic visualization. So either you go the endoscopic or you do the percutaneous transhepatic biliary drainage. So it's important to control the symptoms of the patient, and plus in such patients who are vomiting and there's a bullous vomiting because there's obstruction, you can also put the nasogastric tube so that it actually keeps on draining whatever the bile is being accumulated there. So there can be a proximal obstruction, or there can be a distal obstruction. So actually there is a proximal obstruction in the common bile duct. So for that, it's better to put a nasogastric tube nasogastric tube for that. But actually, in case of the proximal obstruction, nasogastric tube wouldn't be that much effective because actually it drains into the duodenum. So the distal obstruction, if you put the nasogastric tube all the way, so it can be drained in a very effective manner as compared to the proximal obstruction. Now, talking about the transhepatic drainage, again, you actually do the CT visualization, and under that you can see that this is actually the common bile duct, right? This is the cystic duct. These are the common hepatic. This is the gallbladder along with the cystic duct, and the cystic duct along with the common hepatic duct is actually making the CBD. So if you could see the CBD, which is the common bile duct, it's very much dilated. So you do the transhepatic percutaneous drainage. A similar picture is shown here. This is the cystic duct and the common bile duct. This is the cystic duct, and these are the other ducts which are coming from the hepatic part, and these are the common bile duct, the cystic duct. They combine together the common bile duct, and it's very much dilated, and you do all the way, you go percutaneously through the transhepatic route, and you do the stenting. So that was about the descending cholangitis. So pick up the infection as soon as possible. Do not forget about the Charcot Triad. Do not forget about the patient's symptoms. Do not forget about if there is a combination of the fever, right upper quadrant pain, and obstructive jaundice. It is none other than descending cholangitis. And for the confirmation, go for the blood CP, go for the liver function test. Check out for the bilirubin levels if they're increased, or the index bilirubin levels, they're increased along with the increase in the ALT and the ALP. Then manage on the line of the obstructive jaundice, and for that, order ultrasonography or CT, because it's going to give you the information about the dilatation of the CBD, and if needed, you can go for the magnetic resonance cholangiopancreatography. In some centers, they do the endoscopic retrograde cholangiopancreatography when MRCP is already being done. So ERCP plus stenting in the percutaneous transhepatic biliary drainage, that would be the available options you can think about. So that was about the descending cholangitis, plus the a combination of the rehydration strategy with a good broad spectrum antibiotic and good anaerobic cover is important. Then there is another entity which is called as the pyogenic liver abscess. So if we talk about the pyogenic liver abscess, it's simply that there is a liver abscess which is because of the pyogenic infection, which is because of the pyogens. So they're mostly bacteria, and they can be coming from the appendix, or they can be coming from the diverticulitis. So what happens is, like, those patients who has actually the history of the stone and who have other infections like the appendicitis, or they have the diverticular disease, or especially when the diverticulum is inflamed, which is called as diverticulitis. So these can actually precipitate, or there's already the septic focus which is being present in the body. So they can actually travel all the way to the liver, and they can form a pyogenic liver abscess. And these are much more common in those those patients who are immunocompromised, in those patients who are diabetic, because in diabetes, suppression is very, very much common. So always remember, immunosuppressed state, diabetes, then obviously the patient which is already on the steroids, then those patients who has got septicemia, or those patients who has got appendicitis, or those patients who has got especially diverticulitis, very, very common with the diverticulitis. And the causative organism behind this, they can be E. coli, Escherichia coli, they can be Proteus, there can be Staphylococcus, there can be Streptococcus malaria, and the Streptococcus facilis. These are the important organisms which are actually responsible. They're all the way coming within the gut, and they're causing a pyogenic liver abscess. So this is a CT scan of the liver, and it's actually showing you the hypodense densities which are present in the liver. So these are the hypodense areas. As if you compare this texture with the rest of the liver parenchyma, this is hypodense and this is hyperdense. So these hypodense areas in the liver, they're actually indicating about a liver abscess. So again, obviously, the pathology is infective. Then what you have to do? You have to treat the patient on good broad spectrum antibiotic cover. You have to hydrate the patient. You have to monitor for the input-output, and you have to monitor for the other important cardinal signs as well. And you have to monitor for the fever, and you have to look up for the blood count and the seroactive protein, which is usually the quantitative seroactive protein, which would be telling you the progress of the disease, either it's resolving or it's increasing. That would be helpful. The C-reactive protein would be helpful. So precisely talking about the treatment, there's some kind of the first line antibiotics, and you usually combine these antibiotics. Usually only one antibiotic is not enough, and you need to give a combination, a gram-positive cover and the gram-negative cover. So you combine penicillins, which are actually giving more of the gram-positive, and you combine with aminoglycosides and metronidazole, which is actually a triple regimen or triple therapy, combining a gram-positive cover with a gram-negative and anaerobic cover. So penicillins, or broad-spectrum 4th-generation cephalosporins or 3rd-generation cephalosporins, you're combining with aminoglycosides, which are actually giving you a gram-negative cover, and metronidazole, which is actually giving the anaerobic cover. Either it can be a combination between the penicillins, aminoglycosides, and metronidazole, or it can be a combination between a cephalosporin, which is actually more of the gram-negative cover, with the metronidazole, which is which is actually the anaerobic cover. Then sometimes this can be if the liver abscess is huge and it's taking a lot of time in resolution with the use of the antibiotic. Then what you do is you do the ultrasound guided aspiration. So actually, a probe is placed on the right upper quadrant. Ultrasound, the image of the ultrasound is live available for you, and then you can do the aspiration. You go through the percutaneous route, and you do the ultrasound guided aspiration. Or you can even do the percutaneous drainage. You can go blindly without the ultrasound guidance. So the main focus or the main treatment would be giving a good hydration therapy and a good antibiotic cover, first line antibiotic cover, combining with a gram-positive, gram-negative, and the anaerobic cover. These are important. And if you talk about the ultrasound guided aspiration, so actually this is the live ultrasound, and these are the hypodense or hypoechoic areas which are present in the ultrasound. And this is all the vein needle, which is coming straight down from the skin, and it's piercing the liver parenchyma. It's entering into the liver, and by the help of that, ultrasound guided aspiration can be used as a treatment for the pyogenic liver abscess. So talking about the different kinds of the liver abscess, there is another abscess which is called amoebic liver abscess. So always remember that pyogenic liver abscesses, the causative organisms can be multiple, and they're most of the time they're bacteria. They can be E. coli and rest of that. So amoebic liver abscesses, those patients who are traveling abroad, sometimes they actually acquire these amoebic abscesses. And amoeba can cause dysentery, or it can cause amoebic liver abscess. So what happens is like the trophozoite sits into the liver. So it has got a fecal-oral transmission, and it's sometimes transmitted by the unhygienic food, or by the fecal-oral route. So it's actually the trophozoite. It comes and sits in the liver, and it ultimately causes, because when bacteria is sitting inside, there would be immunogenic response, which would be would be activated, and there would be the neutrophils and the macrophages, and then they will ultimately make the abscess. And as like all other abscesses, that abscess would be obviously causing fever and the right upper quadrant pain, and especially the history of the travel abroad will give you the indication about the amoebic liver abscess. So it's important whenever you're suspecting amoebic liver abscess, always ask about the history of the travel. So you can see that this is the liver parenchyma, and this is a large focus of the abscess which is being present, containing of cellular debris and the trophozoites of the amoeba as well. These amoebic liver abscesses, they can be treated. Obviously, amoeba is the anaerobic microbe. So you give a good combination of cephalosporins for the aided, superaided bacterial infections, and you combine it with a flagell, which is a metronidazole cover. So that's important, and you put the patient on a good hydration therapy as well. So sometimes what you can do is you can take aspiration. You can just aspirate the abscess a little bit, and then you can send it for cytology and culture and sensitivity, and they will tell you about the trophocyte. And sometimes the trophocyte can be present in the blood, because although it's coming through the portal blood, coming from the circulation, and fecal transmission coming to the portal blood, and by the help of the portal blood it goes to the liver. So you do the blood culture sensitivity, or you just take the aspirate from the liver, ultrasound guided aspiration, and then it can be diagnosed with therapeutic both at the same time. You go for the cytology, and you also go for the bacteriology and culture and sensitivity. Talking about, since we're talking about the different kinds of the infective diseases, there's another disease which is called as a high data disease. And high data disease is very much important to be discussed, because the causative organism behind this is the Echinococcus granulosa. So actually, the Echinococcus granulosa is usually present in the dog intestine. So what happens is like their ova, they can be transmitted by the fecal-oral contamination, and their ova, they're ingested by the humans, and all the way coming to the intestine, and then entering the portal blood, and it goes all the way to the liver, and then that ova, then actually they are embedded in the liver parenchyma, and they flourish, and obviously they become the full-blown parasite. And they cause the disease which is called as a high data disease of the liver. It's kind of the some kind of structural and architectural distortion of the liver parenchyma as well, and there can be some kind of cystic appearance which is present in the liver. So talking about the diagnosis, ultrasonography and the CT scan, but CT is more diagnostic if we talk about the high data liver disease. And this is actually the CT scan of the liver, and you can the cut section is at the level of the liver, and this is the whole of the liver parenchyma. And if you compare this part with this part, there is the dense hypoechoic lesion which is being present here, and you can see that inside you can see the parasite loculation, a cystic the demarcated area within that, this is giving you the PET diagnosis of the hydrated liver disease. So if you talk about the treatment of the hydrated disease, you first know that what can happen in a patient who has already acquired the hydrated liver disease. So it is possible that this cyst actually remains in the liver and it remained persistent in the size, or it may increase in size and causing discomfort or the right reported pain, and sometimes it can form a full-blown abscess. Or sometimes these larger liver cysts, they can actually rupture, and they can rupture into the peritoneal cavity, they can rupture into the stomach, or they can rupture because the right lobe of the liver is just beneath the diaphragm. So if the right hemidiaphragm is affected, it can cause the empyema. So it's important what is actually the clinical presentation of the patient, right? So if the cyst is not being ruptured, and but it's causing a right kind of the discomfort or the right upper quadrant pain to the patient, then these cysts actually needs to be aspirated. Simple aspiration of the cyst is enough. But sometimes these hydrated cysts, they cannot be aspirated and they're larger enough, and then you have to open and you have to do the de-roofing and you have to do the surgical manipulation, right? Or sometimes it's very important when you're dealing with such kind of the cyst, there is possibility that if the cyst was contained within the liver and you puncture it and you enter the peritoneal cavity, so these small baby which are sitting inside the cyst of the ova or small trophocytes, they can enter small hydrated cysts, hydrated loculations, they containing the organism, they can come into the peritoneal cavity and there can be seeding. So that's important. If you are treating such patients, give a broad spectrum antibiotic. This is important. Give anaerobic cover, give albendazole or mebendazole, because it's a parasite, right? So give the albendazole or mebendazole, start immediately as soon as possible. And you can also give this before starting the operation, pre-operatively, and you have to give per operative dose of praziquantel as well, and obviously the good hydration status, and you also give a good broad spectrum antibiotic if there is a seeding into the peritoneal cavity. So treatment is, if you talk about the medical treatment, so give the albendazole or mebendazole. Then there is another treatment for the hydrated disease, which is called as percutaneous treatment. So what you do in a percutaneous treatment is like you give the initial course of albendazole, and then you puncture the cyst under the imaging guidance. This is very much important. So if you would be doing it blindly, then there's a chance that you may rupture the cyst, or there's a chance that you may enter the peritoneal cavity, and you may cause a seeding of those small babies, echinococcus, or the ova or trophocyte, which are present in the liver. So what you do is you give the initial course of the albendazole or mebendazole can be given. You puncture the cyst with with a needle, which can go all the way percutaneously. And you have to do this procedure under ultrasonographic imaging guidance, and then you aspirate the contents of the cyst. This not only enough if you do the aspiration, then you have to instill the hypertonic saline in the cystic cavity. So what is the role of the hypertonic saline? Actually, those trophocytes or the small babies which are present inside the cystic cavity, they cannot survive in a hypertonic saline. So this hypertonic saline actually kills the remaining of the parasites which are being present in the cystic cavity. And then what you do, you aspirate it, you instill and then you aspirate. So what you do, you need to give the initial course of the albendazole or mebendazole, then you have to go percutaneously under the imaging guidance, ultrasonographic imaging guidance, and you have to aspirate. And after aspiration, what you have to do is like you have to take the hypertonic saline and you have to instill that hypertonic saline into the cystic cavity, and then you have to re-aspirate. So that's how you do the percutaneous treatment. But if the percutaneous treatment is not effective and the patient still remains symptomatic and not only symptomatic, but his clinical findings and the diagnostic and the biochemical findings are still deranged, then you have to do the surgical treatment. So for the surgical treatment, you need to do the liver resection, or you need to go for the local excision of the cyst to deroofing with evacuation of the contents. Now, this is important. This is for those conditions in which there's a large or high data cyst and it's causing a lot of the trouble, and it is suspected that it may rupture into the peritoneal cavity. So what is important is you do the liver resection or you do the excision of the cyst with a deroofing. But for that, it's important that you actually before starting the surgical treatment or preparing the patient for a surgical procedure, you have to give the good antibiotic cover. You have to give the initial course of the albendazole or mebendazole, and per-operatively you need to give the patient the praziquantel as well. And then role of the hypertonic saline is somehow very, very much important. So whenever you are deroofing the cystic cavity, you need to take a saline, hypertonic packed saline, and then you have to keep that within the peritoneal cavity so that there should be no seeding. The principles of the liver resection would remain the same. We will be discussing in our next lecture about the liver resection, how you do it, what are the principles, and what are the important steps and what important structures you need to say. We'll be discussing this in detail in the next lecture. But for today, you need to remember liver resection can be the choice for the high-dated liver disease, or there can be local excision of the cyst, and you actually do deroof it with evacuation of the contents. And it's important whenever you are dealing with the cyst, you do not rupture it. Okay, it's very important, because if you rupture the cyst, there would be seeding into the peritoneal cavity, and you do not obviously want that. And you need to deroof it, and you need to suture that so that the cystic cavity should not form again. And after doing the deroofing or doing the marsupialization or suturing it all along, you need to instill the hypertonic saline into the residual cavity as well. And you need to use the hypertonic saline soak gauze within the peritoneal cavity, and you have to keep it for some time, and then you have to remove it. So that's about this surgical resection of the treatment. So this was about today's lecture. We have been discussing about the acute conditions which are related to the liver. We have talked about the ascending cholangitis, and especially the most important thing about ascending cholangitis is the obstructive jaundice and the Charcot triads. And we talk about the clinical signs and the investigations which are actually going to make us help in the diagnosis. Then we talk about different liver abscesses, like the pyogenic liver abscess and the amoebic abscess, and their treatment lines and their treatment strategies. Then we talk about another important cause, which is the high-dated disease of the liver. The causative organism behind this, again, echinococcus, and you need to differentiate if the cyst is ruptured or the cyst is not ruptured. So in case of the ruptured of the cyst, it can be into the peritoneal cavity, it can be in the stomach, or it can be just in the diaphragm causing the empyema. Then you need to be very cautious in that, because if there is seeding, there can be formation or more of the high data cyst in the peritoneal cavity or in the stomach or in the diaphragm. And the obviously treatment is to give a good antibiotic cover, give the good hydration status, and also most importantly, you have to aspirate the cyst. And the use of the hypertonic saline is very, very much important whenever you are aspirating the cyst. And if the aspiration is not making any difference or helping in the treatment, then you go for the surgical resection, which can be local excision of the cyst or causing with the deroofing or marsupialization, or you do the liver resection. So that's all for today's lecture. Keep watching sqadia.com.